Good afternoon, everyone. This is the glass-mounted specimen of lung carcinoma. Our group will be discussing lung carcinoma, one of the most prevalent and deadliest cancer worldwide. This presentation will cover etiology, gross pathology, specific tumor types, microscopy, and lab diagnosis. Understanding these aspects is essential for proper diagnosis and treatment. Let's begin with the causes and risk factors. Etiology. Lung carcinoma is primarily caused by prolonged exposure to carcinogens. The most common cause is smoking, responsible for approximately 85% of cases. Other important risk factors include: first, passive smoking. Involuntary inhalation of cigarette smoke increases the risk. Second, environmental pollutants. Exposure to industrial chemicals and pollution. Third, radon gas and asbestos exposure, found in certain workplaces and older buildings. Fourth, chronic lung diseases such as COPD and tuberculosis. Fifth, genetic mutations. Mutations in genes like EGFR, ALK, and KRAS are strongly linked to lung adenocarcinoma.
Now let's discuss the gross pathology of lung carcinoma. The first type of carcinoma is adenocarcinoma. It is located predominantly in peripheral area. Its appearance is well circumscribed and it is firm in consistency. Its cut surface is shows fibrosis and growth pattern is along the alveolar walls. The second type of carcinoma is squamous cell carcinoma. It typically arises in central region of bronchi. It is irregular mass, often with cavitation due to central necrosis. The cut surface is reddish color, often hemorrhagic, associated with squamous metaplasia and keratinization. The third type is large cell carcinoma. Type of malignant carcinoma is large cell lung carcinoma. It is found in peripheral region of the lung. Its appearance is large and bulky with soft and hemorrhagic mass. The cut surface is poorly defined with margin and necrotic area. The growth pattern is highly aggressive with early metastasis. Now fourth type is the small cell lung carcinoma. It is centrally located, often involving the hilum and the mediastinum region. Its appearance is diffuse and infiltrative growth pattern with hilar lymph node involvement. The cut surface is soft, fibrous, and tumor with extensive necrosis. The
microscopic features of lung cancer: adenocarcinoma, glandular formation with mucin production. Cells may form acinar, papillary, lipidic, or solid pattern. Squamous cell carcinoma, presence of keratin pearls and intercellular bridges. Small cell lung cancer, small, round to oval cells with scanty cytoplasm. Necrosis is also common. Large cell lung cancer, large undifferentiated cells with abundant cytoplasm. Tumor cells also show pleomorphism with high mitotic rate.
So now, let's continue with laboratory diagnosis and conclusion. For diagnosing lung carcinoma, several laboratory tests are performed, such as imaging studies, in which chest X-ray, which is used for first-line imaging, CT scan and PET scan, which is used in helping staging and detecting metastasis. In cytology, we see sputum cytology, in which helps in detecting malignant cell in expectorated sputum. Pleural fluid analysis, which help in evaluation of pleural effusion for cancerous cell. In biopsy technology, bronchoscopy with biopsy for centrally located tumors, and fine needle aspiration for peripheral lesion. In molecular testing, EGFP, ALK, and KRAS mutation help in detecting targeted therapy. Immunohistochemistry, which is also known as IHC, helps in TTF and NAPA, which helps in markers for adenocarcinoma, P40, P63, which are the markers for squamous cell carcinoma. The conclusion is that lung carcinoma remains a leading cause of cancerous leading mortality. Smoking, early detection, and advance in molecular therapy have improved patient outcomes. New treatments like target therapy and immunotherapy provides hope for better survival rates.